Here's an interesting fact. In Trinidad and Tobago, between 2015 and 2019, there were approximately 40,900 pregnancies annually. This fact leads us to a medical condition that many know very little of. On this episode of What's Up Doc, we discuss gestational diabetes, a form of diabetes which develops in pregnant women and is usually diagnosed in the 24th to 28th week of pregnancy. This medical condition can affect both the fetus and mother, but can be managed to ensure that you have a healthy pregnancy and a healthy baby. To educate us on gestational diabetes, we are joined by obstetrician and gynecologist Dr. Amina Khan, who has diagnosed and treated multiple health conditions in women.
Today's Vitaminate is vitamin K. Vitamin K is a fat-soluble vitamin. Your body stores vitamin K in the liver and other body tissues, including the brain, heart, and bone. Vitamin K is known as the clotting vitamin. Without it, blood would not clot. Vitamin K is found in the following foods: green leafy vegetables such as kale, spinach, collards, mustard greens, parsley, romaine, and green leaf lettuce. Vegetables such as Brussels sprouts, broccoli, cauliflower, and cabbage. Fish, liver, meat, eggs, and cereal. And that was today's Vitaminute.
FanZone, your reliable, authentic supplier, has just gotten better. You can now visit our website www.fanzonett.com for your authentic wear and collectibles. The only place where you can use both your Visa debit and credit cards. Visit our website fanzonett.com to make your purchase today.
Is it politics? What is it? Is it that nobody cares about sports?
The kind of support that sport used to get in the past is no longer here.
The thing is, taking a knee doesn't mean that that's the only thing you're doing on it.
Right.
Taking a knee along with other stuff.
Samantha, what are you looking forward to when you return home to Trinidad and Tobago after winning the title?
Thank you very much for speaking it into existence.
Is it no pressure on Nicholas Ball?
It makes me more motivated to work hard and to go out there and rep the white and black.
Why are we sending a team to the Winter Olympics?
There are a number of Trinbagonians who are in the diaspora and have grown up in winter sport. It's an opportunity that the Trinidad and Tobago Olympic Committee will not close the door on.
I also believe in the players that we have. Once you can motivate the players, you can get the best out of them.
Take some time for yourself or spend some time with the family at Sandy Point Village Hotel. Enjoy our various studio and suite apartments, self-contained with their own kitchenettes and Wi-Fi. We also have our famous 100-foot swimming pool and our beachfront restaurant, the Steak and Lobster Grill. And our location in Crown Point puts us near the center of activity from the nylon pool to the local nightlife. Call us and make your reservations at 639-8533, 389-2378 or email us at sandypointvillagehotel@gmail.com.
Diabetes in pregnancy, or as we call it, gestational diabetes. How common is it in your practice? How often do you see it?
Oh, diabetes mellitus is one of the most common conditions seen in pregnancy. It can be broadly divided into two main types. So gestational diabetes, which will be the main focus of today's topic. And this is diabetes that develops during the course of pregnancy in the latter half. It is the most common type of pregnancy of condition seen in pregnancy, meaning it's about 90% of women who have diabetes in pregnancy have gestational diabetes. However, there is also pre-existing diabetes. So this can be broadly categorized into type 1 and type 2. The majority of patients may have type 2 diabetes, which is due to insulin resistance. And pregnancy itself is a state in which there is insulin resistance, hence the development of gestational diabetes. Type 1, however, is an autoimmune condition, and that is a condition that develops in patients who are much younger, and they depend on lifelong insulin treatment.
So a woman can be completely healthy and become pregnant and then develop gestational diabetes in pregnancy.
Yes, that's very true.
And after delivery, she goes back to being normal, or usually they will develop the diabetes thereafter?
Yes, so that's the difference with pre-existing diabetes and gestational diabetes. So as the name suggests, it is during pregnancy. However, follow-up is essential. So after patients deliver, it's definitely important to have the follow-up investigations at least 6 to 12 weeks postpartum. And based on those blood test results, we can determine if it resolved or if they continue to have existing diabetes.
So diabetes in pregnancy is, as you said, is very common in Trinidad and Tobago. We as women, once we get pregnant, we should screen for it. And how do we screen for it? How do we detect and pick up that we may have gestational diabetes?
Right. So that's very important. Now, because of our sedentary lifestyles, because obesity is on the rise globally, it's becoming more and more common. Now, unfortunately, many women are not screened before they become pregnant. So you may actually have pre-existing diabetes and not be aware of it. So it's important to be screened in pregnancy.
What does that look like? What is the screening test?
Sure. So now we employ what we call a universal method of screening. So everyone gets tested in pregnancy. And for gestational diabetes, they are screened between 24 to 28 weeks of pregnancy, which is when it tends to develop. However, for certain patients who may be higher risk, it's advisable to screen them from the time they join antenatal clinic, which is usually or should be in the first trimester. So, for example, those women would be those who are obese or overweight when they are pregnant, those who are advanced maternal age, so if they're over 35.
That's considered advanced maternal age, right?
Yes, in pregnancy terms. Those who would have had polycystic ovary syndrome, who have hypertension before pregnancy, those who have had a previous bad obstetric history. So, for example, they would have been pregnant but unfortunately miscarried, or had a stillbirth, or had a baby who was macrosomic, or a big baby, so that's over 9 pounds at birth, or if they have had a history of gestational diabetes in a previous pregnancy, then these patients are screened so early on, much earlier, in the first trimester, after they have booked with their healthcare provider.
Right. Most women, you're going to start the screening for diabetes in pregnancy between 6 months and 7 months of pregnancy, which is 24 to 28 weeks. And for those who are high risk, the obese, the polycystic ovaries, the family history, the previous big baby, we're going to start screening them really early, first trimester, the first 3 months of pregnancy.
And this will be to identify those who have, as I mentioned before, type 2 diabetes, but they're unaware. So they are actually diabetic before pregnancy, but they're not aware. So we need to diagnose them early. And in a further discussion, we'll discuss why.
What tests are we going to be doing?
Right, very good. So previously, we used to use certain criteria, such as, for example, detecting glucose in the urine, but now we no longer do that. We screen using blood tests. And these blood tests, depending on which guideline is followed, you can either use a one-step approach or a two-step. The one-step involves doing a 50-gram glucose screening test. So the patients are not fasting. They have a 50-gram glucose load, and 1 hour later, a blood test is taken. If that's elevated, they move on to the 75-gram oral glucose tolerance test. This is the more common one that's used locally in Trinidad, and it's an overnight test as well. So the patients have to fast, and then they come in the following morning where this particular test is done.
So they get the glucose solution.
A very
to
sweetened drink, which is not very palatable, but unfortunately it has to be done.
But before they even have the drink, they do a blood test first, a fasting
yes, so
blood
a fasting
sugar.
blood sugar test, which again, depending on the criteria, we have values that we look for.
Right.
So once it's elevated above those values, we can make the diagnosis.
Suspicion, one
Yes.
time. And you give them that sweet drink to drink, and 1 hour later...
another sample is taken, and then 1 hour after that. So it's 1 hour and then 2 hours.
Okay.
And we use any of those three values, any one out of the three, so the fasting, the 1 hour, the 2 hour, if any of those are elevated, the diagnosis is made as diabetic in pregnancy.
Right. Are there any instances where they might be borderline and you need to repeat?
Right. Yes, very good question. So once any value is above the criteria, we don't say borderline, we just say it can be impaired, but either way, they fall into the same category. So once it's abnormally elevated, they are diagnosed. So we treat them as diabetic in pregnancy, and then we start the management that is required.
And if a woman has diabetes in pregnancy, do they present with the same symptoms as a diabetic in terms of feeling thirsty all the time, feeling tired, run down? Is that similar presentation for women who actually have diabetes in pregnancy?
Yes, it can be. Now, the difficult thing with that is that those are non-specific symptoms.
And it's almost like pregnancy
So pregnancy
symptoms.
itself exactly can cause those symptoms. Pregnancy can cause nausea and vomiting, especially in the first trimester. So it's difficult to differentiate. So
this is why you have to screen.
Exactly.
Yes.
So that's very good because we can't tell, we can't differentiate, and you can't use symptoms to diagnose. So we use the criteria, we use the specific criteria where you can make the diagnosis.
Excellent. Now, what are the treatment options available for these ladies who have diabetes in pregnancy?
Right. It's a very broad management, and it involves a multidisciplinary approach. So a whole host of healthcare professionals. So this would include the obstetrician, the diabetic specialist physician, a special diabetic nurse, and a registered dietitian. Now, ideally, this is the most ideal setting. Of course, in our local setting, we have both the private and the public sector.
Right.
So those who are in the public sector, for example, they can attend their local health centers, but they must be referred on to a specialist clinic. So the tertiary hospitals, or either some of the local health centers have specialized medical clinics. So the women are referred to those clinics where they can see a doctor.
A consultant.
A consultant level, and have the specialist care that is required. Okay. So they need to be, go on to those clinics because they can't be managed in general.
Are they all managed with insulin, or could diet and exercise work?
That's a very good question. Thank God not all women require insulin because it would be very difficult, and it would scare a lot of women knowing that they have to use insulin. So the first line in management is diet and lifestyle modification. So this is where the dietitian comes in, and we can have a specific tailored dietary plan for each individual patient according to her BMI, right? And therefore, and that's most appropriate. So we start with diet and then also lifestyle advice. So with regard to lifestyle, exercise is important in general in pregnancy, but especially for those who are diabetic.
Okay.
Because just exercising 30 minutes 5 times a week, or exercising 15 minutes after each meal, lowers blood glucose levels.
Good. What are the complications of having diabetes in pregnancy for the mom? And what are the complications of diabetes in pregnancy for baby?
Right. So that's the crux of the matter. If women do not control their blood glucose levels throughout their pregnancy for the 9 months, in case of pre-existing diabetes, or in the latter half for those with gestational, there are many, many complications that can develop. And this is the importance of managing properly so we can avoid those and have a better antenatal outcome. So for the mom, for example, many women are at an increased risk of developing preeclampsia. So this is hypertension in pregnancy with protein in the urine, and consequently women can have an obstetric emergency known as eclampsia, which is seizures in pregnancy.
Right.
So, of course, as you may think, it is associated with negative outcomes. Additionally, women are at an increased risk of having to have a cesarean section. And also, even after pregnancy, those with gestational diabetes, once it resolves, 50% of women can go on to develop type 2 diabetes within 5 years. Yeah, and that's a lot.
Yeah.
So, that's the problem for mom. Now, for the baby side, for the fetus's side, it depends on the type of diabetes you have. So, those that have the pre-existing diabetes, from the first trimester, there's an increased risk of miscarriages, an increased risk of fetal abnormalities. So these are congenital. The baby could be born with an abnormality.
Right.
And the reason for that, in the first trimester, so between 5 to 8 weeks, that's when fetal organogenesis occurs, so the development of the organs. If the blood glucose levels are very high at that time, that's when problems can occur.
Right.
And what are these problems? It can be problems with the fetal brain, problems with the cardiac abnormalities, and that's your specialty, problems with the fetal spine, even later on now. So those who have gestational diabetes, what can happen with those babies? So in the third trimester, the babies start to get very big, so they become large for gestational age.
Yes.
There can be suspected macrosomia. So that definition is a baby at birth of 9 pounds or more. And then what is the consequence of that?
This is what I'm now going to ask you, yes.
Right. So the consequence of having an assumed or presumed big baby is a lot, and it can have negative consequences. For example, an obstetric emergency known as shoulder dystocia, and can lead to birth trauma, both for mom and for the baby. So shoulder dystocia is when the head, is delivered, but the shoulder